Okay, I don't have any disclosures. And what we'll kind of be going through is this is the updated Academy of Breastfeeding Medicine protocol that was revised in 2022 on the mastitis spectrum. And it really is a spectrum in the way that you think about other processes in the body, like appendicitis. You don't go from sort of acute appendicitis to an abscess or a phlegmon overnight, and it's more of a spectrum of progression. So we will approach mastitis this way. And this is the whole protocol that's pretty long, and it has a lot of basic science background. But what I would recommend in terms of 99% of what you need to know clinically, this is a handout that we created. The Academy of Breastfeeding Medicine has several clinical handouts that are very, very useful. I use the bed sharing one almost daily. And you can download them at the Academy of Breastfeeding Medicine's website for free. And they also have a link to Zazzle where you can order sort of tear off sheets and just have them ready, and they're in color and ready to hand out to the patients. So this is really the take home message of everything. So I encourage you to check this out. I also have this linked on my website. So just a quick background, I like to just kind of introduce how I came to breastfeeding medicine. And I was born in a very small town in California that's actually probably more like the Midwest than California, a small farm town. And my mom always, when I was growing up, talked a lot about breastfeeding me with the help of the La Leche League. So this is me 3 days old and on the boob, according to my mom. So I was, very grateful to have been a breastfed baby. Actually, everyone in my family was, so it was kind of a culture for us. But, obviously everyone is not that lucky or in that position to have that help. So fast forward to, I was a general surgery resident at Cornell in New York City, and we had a partner hospital in Tanzania and East Africa. And I spent 3 years there as a resident doing research and then returned as faculty after graduation. And I saw a lot of physiologic nursing there. There were pumps, there wasn't, the commercialization of breastfeeding. And also in the hospital, we had little to no access to any kind of pain medication. And if we did have access, the patients had to pay for it, and most often didn't have the funds to do so. So you can see here, this is a baby that we were doing burn care, dressing changes on, and the moms would use the breast for pain control during these dressing changes. So that was kind of my adult experience with lactation. And then fast forward to today, where I really think even from the time that I had my son, coming up on 10 years ago, and pumping, in between cases, running to bathrooms and various things, to now this is actually a scrub who was wearing a wearable pump in the OR with me in a case. This was about a year ago. She's still pumping because I'm not usually at that OR, but was with her a month or two ago. And sorry, she's not still pumping, she's still breastfeeding. And she was telling me a story in this case of breastfeeding her first two kids. It didn't go particularly well. She was a scrub. If anyone's familiar with the power dynamics of the OR, usually the surgeons and the anesthesiologists have a bit more of a voice and can kind of speak up for ourselves. But scrubs don't necessarily have the opportunity to say, hey, I need to pump, or hey, I'm wearing wearable pumps. And so it seems, you think of where we started back in small California farm town to now, where a scrub is actually wearing wearable pumps in the OR and is therefore maintained her milk production and is feeding. I think her baby's a year and a half now, maybe, or something. But a lot of good changes over time. So in terms of what we will go through today, it's really just kind of an overview of how we progress down the spectrum of conditions, and really most of the prevention is the same as the treatment. So it should, hopefully you'll hear a lot of resonating themes. And then also when we look at, I think we have to just take a little bit of time before we get going to think about or understand where we were with mastitis in the past, and where we're going, and why we're kind of questioning a lot of things that were recommended before. And I always think of this moment when I had a patient several years ago who was seeing me for mastitis when it, wasn't getting better with the usual interventions. And I said, what have you been doing? And she told me this whole routine, which unfortunately is not that uncommon. And she said, I was told to soak my breast in Epsom salt. Then I was told to pump. Then I was told to apply castor oil wraps on top with a heating pad. And then she said, our kitchen looked like a Breaking Bad episode. And that always stood out to me, because actually I lived in my first practice was in New Mexico. And unfortunately, Breaking Bad is not really a parody. It's actually true in a lot of ways there. And so I just always said from that point in time, Matt, breast feeding should never look like Breaking Bad. If it does, then you need to change something, because this is an organ in our body and we need to treat it that way. We would never treat appendicitis or, say a tubal ovarian abscess, anything like that. And then she was also told to massage and pump and then do breast gymnastics. And I realize that people are trying to sort of be cutesy when they're using terms like that, but ultimately I think it devalues what we are doing and where we're trying to get with the care of lactating women and babies. And really, we deserve to use precise language and, not think that sort of shaking our breasts is the way to treat anything. So again, I appreciate people are trying to be lighthearted, but ultimately it kind of detracts from where you want people to be in terms of actual treatment. And then obviously, I'm sure everyone is aware, going from open gynecologic procedures to robotic procedures today, same thing with surgery. And really, this is where all aspects of medicine evolve, and this is what we're doing with lactation. And ultimately, change is hard, but I think it's really the patients that are driving it too, because they're the ones that recognize that what they were recommended to do wasn't making them better. And this is just someone, I got permission to share this email from someone who said, it was just a good description of, she said, I was instructed for the first 6 weeks by my OBs and midwives to heat my breast hotter to melt the cheese balls in my ducts that were apparently causing antibiotic resistant mastitis. They also had me heating, nursing, and then heating and pumping every 2 to 3 hours to keep the breast empty. It was utter hell. I now know my intuition was right, that I didn't have any clogged ducts at all. I had severe engorgement and inflammation and just lumpy sore breasts. My breasts were red because of that, and I didn't need 3 rounds of antibiotics and to tell my body to make enough milk for twins. And then she said, I will also add that it was recommended because I wasn't getting the tissue hot enough that I used a crock pot of hot washcloths to heat the breast before pumping. It was scalding hot. I was essentially burning myself. I remember leaning over my kitchen counters to quote unquote straighten out the ducts, scald my breast at 3 a.m. every 2 to 3 hours, and I was bawling my eyes out. It's not what I thought early motherhood would be like, and I went to some really dark places mentally. And then she's, continued, because of these new recommendations, I handled a clogged duct last week with confidence and kindness towards my breast, and it resolved quickly. Nursing, ice, and ibuprofen makes so much more sense than the alternative. And then, obviously in the lactation world, people are processing on, various listservs and, how to sort of evolve. And this is someone that's saying, I know you and others are having a difficult time with the new recommendations, but I'm seeing much faster resolution, happier breastfeeders using the gentler approach. And then this was a lactation consultant that also said, I started going in this direction roughly 15 years ago. And, just kind of using common sense about how you would treat a breast. It's been a game changer from what I was taught earlier. And so why didn't these things in the past resolve issues? I think there was some misunderstanding of breast anatomy and physiology, which we'll go over. A lot of repeated interventions, for example, repeated antibiotics without addressing the root cause of problems. And the adage in medicine that if the cure works, you have the disease, I think really applies here, because if someone actually had an infection, the antibiotics would treat it and it would resolve it and people would move on. They wouldn't need 5 different courses of antibiotics, i.e. you're not treating the right disease if you're not getting resolution. And then of course we have moved away from feeding physiologically as we used to do in traditional cultures. And in many ways, obviously those of us who had to go back to work or otherwise separated from our infants can use pumps to maintain our milk production. But the sort of overdrive of feeding and pumping and the pump industry has unfortunately caused a lot of additional problems. So when I think of the way I described the lumpiness and the redness that people get and kind of where some of the mix-ups with understanding were before, I think of Southern California freeways. And I imagine you don't have the same problem that we have with traffic in Los Angeles, but any analogy you have locally that would make sense. But I describe the breast as all the houses surrounding the freeway are what contain the milk, right? So the alveolar cells manufacture and store the milk. So when people are lumpy, they're just feeling people, lots of houses full of people. But when you tell your body to, you stimulate it by overfeeding or overpumping, you're just telling more people to leave their houses and get on the freeway. And you just end up with more cars on the freeway, and it just causes more and more of a problem. But you actually want to do is just wait for that traffic jam to clear and not get on the freeway at 6 in the morning when everyone else is on the freeway. So just understand, the more you stimulate it, the more swelling and the more problems you're going to get. And we only have a tablespoon or 2 of milk in our ductal system at any one point in time. So it's impossible to have a quote unquote plugged duct. There are hundreds of millions of ducts in your breast. They're not going to be plugged like a tube of toothpaste. People are feeling lots of blood flow, swelling, distended alveolar cells, but not discretely plugged ducts. The other consideration is that milk stasis isn't a thing. This was created out of a theory about mastitis. And again, milk doesn't hang out in our ducts in a cesspool of bacteria. It's not the breast is not a bladder. It's not a static repository. It's a gland with feedback inhibition. And just like every other organ in our body, it was made to feed irregularly. We wouldn't be at this point in time, we wouldn't be here today if our ancestors had to feed on a 2-hour schedule, or else they would get mastitis and die. So we all know that newborns will cluster feed and then maybe take a break. 3, 4, 5 months old will decrease their daytime feeding quite a bit and then pick up feeding overnight. Toddlers definitely don't nurse on a schedule. So if milk stasis were actually the issue, moms of toddlers would have the highest rates of mastitis, which we know that isn't true. And just think about any other human organ. It doesn't need a schedule. We don't get a bowel obstruction because we don't eat overnight. We don't get pancreatitis because we don't eat overnight. In fact, pancreatitis is a complex inflammatory condition that to treat it, you actually have people not eat to decrease blood flow and decrease secretions. So I'm always telling people, particularly with the app culture today and the pump culture, that we are not robots. Our breasts aren't robots, and we are engineered to accommodate our daily lives. But the difference is that the breast is a gland that you can feel, and there's a lot of folklore surrounding it. So people, are going to be touching their breasts and feeling their breasts and thinking something's wrong in a way that you don't recognize that every single day your bowel is distending and peristalsing and bloating and narrowing, and no one's paying attention to it because you can't actually feel it. But same idea, overfeeding at the breast, the way we've told people to pump and feed in the setting of mastitis, it's just going to make things worse. And it's just like a bowel obstruction. You need to let the edema, inflammation, blood flow resolve, or else it's just going to get worse and worse. And then I have these are just random little table grape decorations from Mexico, but I have this in my exam room and I just use it to describe what people are feeling. So the alveolar cells are like grapes and the ducts are like the connections of the stems with the grapes. But what you're feeling when you're feeling a big lump, it's not a duct. You're feeling all these cells that are distended and you're feeling a lot of blood flow. And I use the analogy of, these are nice, healthy, delicate grapes. However, if you're carrying some grapes home from the market and they get smushed in the bottom of the bag, they're going to start to get juicy and they're not going to, taste as great. They're going to be a little bit bruised. And then, but if you kept on mashing them and, really like stepped on the grapes, that would turn it into grape juice. And that is an abscess. A lactational abscess is 100% preventable. If people don't massage their breast and heat it up, they don't get an abscess. And then the other issue of heating the breast, as that patient described, to release the stuck milk. The milk is stored in alveolar cells. It's not stuck in ducts. The breast is already body temperature or higher, and it's very warm already. It doesn't need a crock pot of washcloths to help it work. We would never heat any other organ that way to make it work. And if you imagine heating a balloon, and you're just bringing more and more blood flow into that balloon by heating it, eventually it's, obviously our breast can't pop, but if you imagine bringing more and more heat, more and more blood flow to that breast, and it's just going to get more and more distended and more symptomatic. And then when people say, well, then why does heat work? For people to say before pumping, it's because it's a relaxation ritual, right? So if you are otherwise kind of not looking forward to pumping, but maybe, you take a break, you're looking at your phone, you're heating your breast, you're going to relax. But it's not because your breast needs that to work. So just kind of now getting into the protocol, because that background is really, I think, important to understand about how we got here and why we revised this protocol. So a lot of what is underlying the conditions on the spectrum is hyperlactation or oversupply. So there isn't any precise definition of this. It's really production of milk in excess of what a baby needs. And if the mom is symptomatic from, lumpy red breast, not feeling great, constant engorgement, just leaking milk everywhere, the baby is having blowout diapers and is spitting up and is, having supernormal weight gain, i.e. it's problematic. It's really a clinical definition. And I don't know if anyone remembers the singer Kenny Loggins from the 80s and 90s, but he is a Santa Barbara local, and he has all of his kids live here, and I've actually taken care of all of his grandkids. He has 5 now. And this is one of his daughters, Bella, on the right of this picture, and that's her wife, Jordan. And Jordan had massive overproduction. Again, it's just something that you deal with based on mom and baby symptoms. So I'm plugging in quotes because, again, it's a term that is out there. So we have to, address it because that's what people use, but it's not actually a plug duct. When people are describing plugging, the vast majority of the time, they're just describing full prominent breast tissue. So just lumpy, full breast tissue. And this is just, a breast ultrasound with the skin, all this dense tissue. These are some ducts. This is a more dilated duct. Or technically, sometimes people are describing blebs where, bleb disease is really not particularly well understood in terms of effective treatment across the board. But we do know from the basic science literature that we talk about in the protocol from someone named Juan Rodriguez, a PhD in Spain, that really the epithelium, the lining your ducts, it's, active. You have dead cell sloughing, you have dead components of breast milk like cholesterol, biofilms from bacteria, not that they're necessarily problematic, but everything is interfacing, and sometimes this sloughs and narrows the duct, and you'll see it as a bleb on the surface of the nipple. But again, vast majority of the time people are just feeling prominent breast tissue. And then in terms of where do you draw the line between plugging in quote unquote mastitis, it's not really a distinction. You treat them the same way. Maybe mastitis you could consider to be a bit more symptomatic. And then infectious mastitis is when we want to use antibiotics. So non-infectious mastitis, just plain old mastitis, i.e. inflammation of the mammary gland. This is a classic photo. So breast pain and redness, inflammation. So you are seeing lymphatic streaking right here. This mom is engorged, has a lot of milk, and her lymphatics that live right under the skin are having trouble draining extra blood and extra lymphatic fluid back into her chest wall. So this makes the breast lumpy. People don't feel good. The breast is incredibly metabolically active when it's lactating. And so people are going to throw off all these inflammatory mediators into their body when they're engorged. But this is classic, just interstitial fluid. If someone has a true infection requiring antibiotics, it is going to be focally beefy, red. That's a typo, red, R-E-D, with cellulitis-like changes. So cellulitis is when there's boggy, indurated, focally red, you have to, the vast majority of the time, to need antibiotics in the setting of mastitis, you have to have done some tissue damage with massage, or you have something very non-physiologic going on, like massive overproduction of milk and the setting of exclusive pumping, and it's just the equivalent of being a dairy cow. The reason why dairy cows need so many antibiotics and have so many problems is because they are exclusive pumpers with induced hyperlactation. So not natural for any mammal to exist like that. But it's important to understand that systemic symptoms don't necessarily equal an infection. The lactating breast is profoundly metabolically active. So again, when there's a lot of blood flow going to the organ and things are congested and people don't feel great, you can have flu-like symptoms, you can have fatigue. People also, the issue is that things like tachycardia, panic, and anxiety are also incredibly common in the postpartum period, as are vasomotor symptoms and thermoregulation challenges because of the low estrogen state. So it'd be like perimenopausal women having a hot flash, and every time they have a hot flash, they're taking their temperature. And so it's, and then kind of people panic and they say, oh my gosh, I'm going to have an infection and, this is life-threatening. I'm going to die and end up in the hospital. My baby will be alone. Literally, people go from 0 to 100. So it's really important to reassure people you can't get an infection just from sleeping overnight. Again, our bodies aren't robots. What you can get is engorgement. You're going to get congestion of the lymphatics, capillaries, pain, but it's not infection. You don't have a necrotizing fasciitis, flesh-eating bacteria just develop in 12 hours sleeping overnight, or if you never pumped at work that day. And then this is just, PET scan. This is actually one of my postpartum breast cancer patients. So, this is where we look for disease, metastases at other sites in the body. And this patient, unfortunately, had progressive breast changes in her left breast throughout pregnancy, and it unfortunately wasn't recognized as being problematic. So by the time she had the baby, the nipple was inverted, this breast was pretty retracted and small. And unfortunately, her right breast was normal. But if you see, this is her lactating right breast. So she was fully lactating on this side because this breast just was in not great shape. So this is her cancer over here. She had a multicentric cancer. So it was in more than one place in her breast. But the metabolic activity of this lactating breast is higher than that of a cancer. So when people don't feel great, this is why all your blood flow is going to your breast. The other thing to understand is that red isn't always infectious. A lot of the time it's not, and fever is not always infectious. So many things cause redness of the skin: hives, dermatitis, blood clot, sprained ankle. This is a patient of mine who, used ice directly on her skin. And so she felt completely better the next day, but she said, my breast is still red. And generally, I don't prescribe antibiotics over the phone. I see people in person, but this patient was traveling. And so, talked to her on the phone, told her, just use some ice and take it easy. And, checked in and she said, everything's fine, except my breast is still red. And sure enough, she had just burned her sensitive skin with ice directly on it. But it's why it's so important to not treat people over the phone. And truly, I last prescribed antibiotics more than a year and a half ago, and I see people in my clinic every single day. So really high volume, and for an uncomplicated early mastitis, again, it's incredibly uncommon to need antibiotics. Sure, you may need antibiotics in people that have, been doing a lot of massage and they cause cellular injury and it's a setup for bacteria and a true cellulitis. But in this situation, no. And then other things that are important to understand is that, for example, in pancreatitis, it's been long established that early antibiotics actually worsen outcomes. So people with pancreatitis come into the ER and get admitted to our surgical ICU, and they are doing very poorly. They sometimes end up intubated. They are very unstable. They require, pressor support for their blood pressure, but it's not infection. It's inflammation. Also acute respiratory distress syndrome, paraneoplastic syndrome. If you have a cancer, you can be, some cancers can make you feel systemically symptomatic. And then another big one is panic attacks and anxiety. And I explain it to people as, think of taking your dog or cat to the vet, and they're usually, panting and sweating and shaking. Or, someone with stage fright, they're not going to necessarily love speaking, and they could be, sweating, alternating with, shaking out of anxiety. So the mental health overlap is tricky, and another reason to see people in person. Other things that are red that are inflammation but not infection: granulomatous mastitis. This is a really good example. This is an autoimmune condition that is analogous to Crohn's disease, but occurs in the breast. And this person, you can see this erythema here, but this is inflammation. This is a great example of hyperemia, or just too much blood flow in a breast. This patient was instructed to pump to empty after a first episode of mastitis in this right breast. And as you can see, she massively upregulated this right breast and was diagnosed with recurrent mastitis. And she came to me and I said, you just got to downregulate this breast. This is not infection. This is all just congested, too much blood flow going in, not enough blood flow going out. And it's also, when you think of, venous congestion outflow, it's just like an erect penis or clitoris, that it gets a lot of blood flow going in. There's not good drainage out. And so you're going to get, color changes, engorgement, and it's, but again, it's not infection. So bacterial or infectious mastitis, i.e. when you do need to use antibiotics. So the vast majority of the time, vast majority of the time, people have been told to massage their breast and heat it up and continually pump. And that's when you cause the cellular injury that sets your body up for an infection, because bacteria love blood. They love the broken capillaries. They love the injured cells. So, this focally, and this is really more of like a palpation on physical exam. But, beefy, indurated, focal, plus she had massaged quite a bit and was pumping. So I always tell people, we it's not that we won't prescribe antibiotics because there's, a hang up of sort of needing that. So I don't tell people no, I just say, hey, 99.9% of the time we don't need antibiotics. So let's just try ice, and, you can use Advil and Tylenol for 24 hours. It's not something that's meant to be used chronically, but obviously, in the acute situation, the same way we would prescribe it perioperatively. And I know the GYN world is using very few narcotics, like surgeons at this point. And so everyone's very familiar with the perioperative doses of Tylenol and Advil. That's what we're talking about in terms of relieving pain for a short period of time. But really, it's the ice and not overdoing it with pumping. And then another great example of why nipple trauma gets cited as a cause of mastitis. So it is an association and not a cause and effect. If everyone that had any kind of nipple trauma was susceptible to mastitis, then we would we wouldn't have survived as a species, because nipple trauma is not uncommon. But this person had massive overproduction of milk, and the baby was struggling to, stay on the breast. And then she was pumping, causing injury to her nipple with pumping. You can see the flange, the flange and the edema here. And then with all this, she got lumpier and lumpier, and she was heating. And then, then ends up with a mastitis, but it's not because of the nipple trauma. This is just, it's existing alongside of it. But our nipples are open to the air regardless. So it's not like having a little bit of, trauma there is going to cause this deep-seated soft tissue infection. The other thing is there's no basic science evidence to support poor hygiene or being run down. So it's, again, likely an association. Why do we see so much peak in mastitis around the holidays, when people are traveling, when they're getting ready to travel, when they're otherwise stressed, when they're going back to work? It's the association, and it's that, moms are stressed in general. Are they potentially paying more attention to their breast? Are they feeling more anxious? And so then the mom, sort of reacts and starts doing things that are not helpful. And then she massages and overpumps and does, develop a true infectious mastitis. The other thing is trying to get out of the folklore, the idea of Candida mastitis. I don't know how this ever got started, but Candida exists naturally in our body everywhere. Our GI system, our respiratory system, the breast, it exists alongside bacteria, but it's not the cause of breast pain, and it doesn't occur on the nipple. It is just not something that that is the way Candida occurs pathologically in the breast. It'd be like asking every breast surgeon out there, are we giving prophylaxis of Candida for our surgeries? It's just, it wouldn't occur to anyone that this would even be a thing. And then kind of moving down the more complicated aspects. So a phlegmon. So phlegmon is a radiographic and surgical term for a complex mass without a focal drainable collection. So meaning that it's that idea of, you have nice healthy grapes, you start to crush them. You haven't crushed them into grape juice, but they are not doing well, and they form a lump. That a lump without a fluid collection like an abscess to drain is a phlegmon. So people should, if you see a lump like this, people need an ultrasound. And hopefully if you catch a phlegmon early enough, it won't progress into an abscess. But it can go either way. And, we think of phlegmon, pelvic inflammatory disease without a discrete abscess. That is, another example of a phlegmon. And, I always tell people I'm operating on the breast that this is what the breast tissue looks like. It's just white chunks of just a big white chunk. So it looks like calamari. It has a texture of calamari. This is what you're massaging. And then otherwise, this is just subcutaneous fat, and you're massaging that and damaging the fat. So you just want to keep hands off the breast at all time. I'm sure we've all seen this bruising from massage. This person is a little bit more indistinct from a physical exam perspective, but, you know, a supple breast over here, and this one is just inflamed and phlegmatous over here. So again, if you keep taking those grapes and they're starting to get bruised and damaged and you keep smashing them, you're going to end up with an abscess. And the risk factors: massage, hyperlactation, pumping, you know, not treating mastitis well and continuing to heat it up. And people at this point may not have systemic findings. Usually it's a physical exam finding, but it's definitely never ever wrong to get an ultrasound if you have any question about the breast. And this is an unfortunate person that you see the progression from a lot of massage and a phlegmon here to this, unfortunately went in the wrong direction, and it all coalesced into literal breast soup and an abscess. And, you know, she had done so much damage and done so much pumping. This is, you know, I drained almost 500 cc's of fluid from that breast. It was very, very unfortunate. And then finally, galactocele and infected galactocele. So a galactocele is a milk-filled cyst that becomes solid, and it can become quite sticky and solid. So this is classic galactocele, just a big black hole full of milk, but it can actually become, it can look a lot more like this over time if it that milk gets inspissated. And so traditionally in surgery and radiology, we're taught that we need to aspirate anything in the lactating breast. The problem with that is that breast milk is very different from simple breast cysts. So simple breast cysts are analogous to lemonade. You stick a needle in, it easily drains out, and you're done. Aspirating a galactocele or a breast abscess is like trying to aspirate yogurt through a needle. It gets stuck and you just can't get it drained. And then you have to keep on going back and draining over and over again. And then at that point, you just convert an uninfected galactocele to an infected galactocele. So at this point in time, I just offer people a small little tiny drain up, you know, just stick in a catheter for, you know, 3 days, drain it, move on, rather than having people, you know, come back and back and back. Unfortunately, we've actually changed this in our Choosing Wisely guidelines for the Society of Breast Surgeons. We talk about this in the protocol, and hopefully we can start to move this way, because in the past, people accepted that, you know, 50 to 60 days, oh, you can resolve a galactocele with aspiration. Well, 50 to 60 days is a lifetime in a postpartum woman. And frankly, it's a lifetime in anyone with a fluid collection that isn't resolved. But you think of a mom having to come back, and she has a new baby, and it's just not the way you want to treat it. So that's kind of the background. And really the prevention and treatment overlap. It's all very thematic. So this is not something from the protocol, but this is just a mnemonic I created for my staff, to just, when, you know, patients are calling in, and, you know, the instructions that they're going to give to the patient while they're triaging them. And like I said, Advil and Tylenol can be used for brief periods of time. 24 to 48 hours is not something anyone should be using repeatedly. Ice is really the mainstay of everything, and treating your breast well. So breast rest. So just don't beat up your breast. If, you know, it's not wrong to feed on your breast, but if you have an overproductive breast, don't keep pumping it like crazy. Don't keep overfeeding it. Just, you know, focus on the other breast a little bit more and try to downregulate that overproductive breast. And why ice? We all know its long-standing use as a vasoconstrictor. It's going to diminish the inflammatory reaction, reduce edema and swelling, reduce tissue metabolism and vascular permeability. And we folded engorgement treatment into our protocol because it's really the same principles as treating mastitis. So ice, supportive bra. There's no benefit of cabbage or other expensive products over ice. It's really just the fact that cabbage can be put in a freezer or refrigerator and then applied to the breast, but the problem is it wilts right away. And in most places in the world, it's just not easily available. and, only feed what the baby needs. We don't want you to over pump. And then you can use some pharmacologics for extreme engorgement if the skin is threatened, but I rarely use that. This is a person I actually did use it in because she had such profound engorgement. I was concerned about tissue necrosis of her skin. But you see her milk came in so fast, her bra was not remotely adequate to support these breasts. But once we got her doing lymphatic drainage and, had settled in terms of, getting an adequate bra and, not overfeeding the baby, that settled down quite a bit. But you can see she had nipple trauma. This baby was just like struggling to deal with these breasts, but she never, never needed antibiotics. Just recognizing all this redness, this is just interstitial fluid. We have this in the protocol. This is lymphatic drainage, extremely easy to do. People don't have to pay money for this. Just it's literally brushing fluid, like petting a cat. You want to lift the skin off the underlying lymphatics with the flat of your hand. You don't want to push down. I will say this is used for lymphedema. I find that people, when, people want to have people touching their breasts. And so if they know, okay, you shouldn't be massaging their breasts, and people are saying do lymphatic drainage, and it's really used for breast lymphedema. It's not like every person out there with a lumpy breast should be doing lymphatic drainage. That said, light brushing also raises oxytocin levels. So if it's going to relax someone, great, go ahead. But it's really not the treatment for just a lumpy engorged, say 2 months down the road. This is really more like pregnancy edema and early postpartum engorgement. And I also have that linked on my website there, if you want to just download that directly. And then this is how you do it, flat of your hands, brush, brush, brush. It's not digging in your fingers in any kind of way. So plugging, same idea as mastitis. You just don't want to overfeed. You want to educate people about this is not dangerous. It's uncomfortable. It's cellular distension, but it will get better if you don't keep upregulating your breast. We mentioned therapeutic ultrasound in the protocol as adjunctive therapy. I rarely use this. I have this in my clinic. We use it on post-radiation fibrosis, and it's also used in different parts of the body. It can, if you have the right patient, it can help. It's certainly relaxing, but I otherwise wouldn't, people want to make a business out of lots of different things. And, people just going for repeated therapeutic ultrasounds that they're paying money for, that is just not the use of the protocol that we want. This is just mentioning this if this is available as an adjunctive treatment, but 99% of the time, you're just going to treat with ice and resolve. When people talk about, massage versus hand expression, hands-on pumping. So hands-on pumping is just if you're using your breast to help hand express, when the pump is obviously not a great, product in general. But that is not, taking a vibrating device and digging it into your breast. It's much more related to just expression of milk. Blebs. So unfortunately, again, like I said, the literature is very sparse on this, and the one published cohort is one of mine, where we really just, it was kind of a shot in the dark, and we're looking at different kinds of lecithin and found that the powder was the best. And, people seem to resolve with the kind of standard 10 grams that you would use in, for people that are taking it for cholesterol reduction. But it's really very specific. People shouldn't just be taking lecithin or other herbs or that's a supplement, not an herb, but in general, you want to use lecithin if you have a bleb. You don't want to use lecithin if you think you have recurrent plugging or you're, lumpy. That is not what lecithin is for. Mastitis treatment, just the same theme here. Examine the patient at predisposing factors, address mental health. Probiotics are another thing that people like to prescribe or recommend. They're very expensive. We still need a lot more data on these. And again, the vast majority of the time, it's just a bag of peas that people need, frozen peas. And you see how it's so easy to resolve things with treating the breast right. So this is, typical, that streaking that I showed you earlier. This is how her breasts look together. And then, 48 hours later, completely, totally resolved with conservative measures. This is someone that caused an abscess. Unfortunately, you can see exactly where she dug this vibrating device into her skin right there. And, we had to drain this. And then 6 months later, she actually came back with this very early mastitis, and easily resolved this. She knew what to do this time, but you can see this is just engorgement here. You can see the venous distension. She's just not getting great outflow of blood in the breast, but after ice, it calms it all down and everything settles down. This is that patient with that profound hyperlactation. I had her basically, feed one time here, feed here again, feed here again, feed here again, and then kind of top off, let this leak, and resolve very nicely. And she continued to breastfeed, this baby for 2.5 more years. Never needed antibiotics again. Never needed antibiotics with the second baby. Just recognizing what is infection and what is not. And the people that have recurrent mastitis, because we've all seen them, this is really where you want to check in about mental health and how people are doing in general, whether they're potentially having anxiety and, they just happen to have a breast. And so it's sort of being focused on the breast. There's also something I call irritable breast syndrome that's analogous to irritable bowel syndrome. It's kind of the same symptoms of, people may be fine one day and then they feel their plugging or they feel their redness or the fullness. The next day they don't feel good, and then it kind of goes on, and it's just like people that have like a couple good days with irritable bowel syndrome and then they're bloated and not feeling great. And a lot of these people are just very sensitive to kind of stretch and engorgement for whatever reason. And they often will feel, I've had people describe almost like a suffocating feeling when their breast feels full. And it's not that it's in their head, it's just their body's perceiving that stretch in a different way. You can have two people with exactly the same, volume of milk, but one person just feels lumpy and feels full and feels like they just need to empty that milk out, and they get like a relief after they empty it out. But it's just this bad cycle. And just like irritable bowel syndrome, irritable breast syndrome resolves beautifully with SSRIs. So the class of drugs that we normally use to treat anxiety and depression, it works incredibly well for breast pain. It desensitizes nipples as a side effect. And it also just reduces that kind of urge and fullness feeling that people get that's very uncomfortable. As I mentioned earlier with abscesses and galactoseals, so the standard that we're kind of taught is needle aspiration. However, this is very difficult to drain effectively most of the time with a needle. So a little tiny drain that's going to be the same skin defect as a needle is often, 99% of the time, that's what I'm using. I give people the option, but it's the same defect as the needle there, and gets it resolved in a couple days and you move on. And this is how I do it in the office, just with a little stent. You can also do this with a Foley catheter. Very straightforward, tiny little incision with an 11 blade, stick in anything you can put in a Foley catheter. I use a little less than a penny Penrose drain. I keep it in. This person is, this is 3 days later, and then this is a week later. So very straightforward. And I have a link of how to do this on my website. I also present the Society of Breast Surgeons. And then just kind of a couple concluding points that it's, you can continue to feed from an affected breast, just don't overfeed. The idea is let it calm down if it's really overproductive, but it's not unsafe to give a baby a breast with an abscess. Intervention, support, encouragement. This is some of my staff, and it makes all the difference. So really, really important. When you are doing procedures, just remember, sometimes mom wants the baby there. So this is a baby that just slept right through a galactoseel drainage of mine. So, sorry, I have a puppy that, no. I said, I 100% could have another baby that would be easier than this puppy, because you just, they're in diapers, you put them in a carrier, you nurse them. The dogs, you have to, train out of barking and potty train. And so she's lovely, but she's a little barker. And galactocele treatment, as I mentioned, a little tiny drain. And this is what galactocele fluid can look like. It's not infected. It's just stagnant milk, and it can look green. And we have this published in the plastic surgery literature too, about operating on a patient with an infected galactocele infected implant, and she continued breastfeeding. Mental health, I can't underscore this enough. This is why I did my perinatal mental health training, because it overlaps so much with my lactation practice, and people really can have some overlap of hypervigilance and even OCD after some of these experiences. This is not part of the protocol, but this is something I just made for my OBGYNs and urgent care and ER. And this is just a PowerPoint. So if you want to, adapt it to your local hospital, I can send it to you, or you can download it. So the take-home points: physiologic feeding. Don't try to keep the breast empty. Just feed normally. Eliminate the pump if at all possible. If someone is pump dependent, then just remove the milk that they need, not 10 ounces more. No massage. Ice is going to resolve the vast majority of issues, and a little tiny drain, rather than sticking a needle in over and over and over again, is going to be the best option for fluid. And if you ever want to visit the Central Coast of California, we have an elephant seal rookery about 2 hours north of where I live on the coast, and they give birth from January to March, and you can see them from a little viewing deck, and it's really, really amazing. And you get to see, usually there's a single pup with a mom, but a bunch of pups got lost, I guess, and ended up with this mom, but really, really neat. And this is my website. You can get there via my name, katrinamitchell.org. And this is a section on, engorgement, mastitis, and everything related. And that's it.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.